Okay, thank you very much. Hello everyone, my name is Arthur Renaud. I work at the University Hospital of Angers. I used to work in Nantes, but what a pretentious title, right? If I knew it was okay to give a funny title, I would have called this case maybe we didn't understand anything until the end. But let's return to a more serious tone. This is the case of a 39-year-old woman with a long-standing history of allergic asthma and the discovery of a focal nodular hyperplasia in 2015 in the liver. Her family story was notable for multiple malignancies. She was a past smoker with no other toxic use, and she was on classic asthma therapy and oral contraceptive. Her clinical journey began in 2020 with a programmed cholecystectomy for gallstone. During laparoscopy, the surgeon discovered multiple millimeter-sized retractive nodules on the parietal peritoneum and an abnormal aspect of the liver. He did a great job and converted the procedure into laparotomy, removed the gallbladder as planned, and performed liver biopsy along with peritoneum biopsy. Unfortunately, histological analysis described only non-specific lesions. The patient was subsequently referred to our department, where she was seen by a now retired colleague. The physical exam and the blood analysis were unremarkable, and ultimately, a full-body CT scan and a PET-CT showed multiple mildly hypermetabolic nodular lesions involving the axial and proximal skeleton, the liver, and to a lesser extent, the lungs. So my colleague was facing multinodular systemic involvement of unknown origin, so he promptly programmed the CT-guided bone biopsy, but unfortunately, the patient never showed up. 2 years later, she was admitted to our institution for a newly developed ascites. That's where I stepped in. What a fool, I had no idea back then. Physical exam was normal, especially no signs of cirrhosis and well-preserved overall conditions. Repeated paracentesis yielded exudative and sterile fluid without abnormal cells. Very extensive blood analysis workup didn't bring any significant information, and follow-up imaging showed no progression of the lesions. A transjugular liver biopsy was performed with a portal catheterism that confirmed the presence of portal hypertension, and the histological analysis showed no signs of fibrosis, no neoplasm, and no inflammation, especially no granulomas. But it noted the presence of centrilobular sinusoidal dilation. At that time, we referred our case to a local multidisciplinary consultation meeting, and the conclusion was this very, very elaborate sentence. To sum up, nobody understood what was going on for our patient. So began our very difficult clinical diagnostic odyssey. We performed multiple biopsies to these poor but very willing patients. Bone marrow biopsy, laparoscopic peritoneal biopsy, CT-guided bone biopsy. None of them were conclusive. In the meanwhile, we were facing a refractory ascites requiring 6-liter paracentesis weekly, despite maximum tolerated diuretic titration, and even a transjugular intrahepatic portosystemic shunt. At the same time, we literally called everyone at our institutions, especially our pathologist, Dr. Galmiche, who I very thank for her dedication. At the end, we did a second transjugular liver biopsy that showed the previous findings, but also extramedullary hematopoiesis. So, you know, I called the hematologist. Here is the scene. Hello there, what do you think of this? I don't know, do another bone marrow biopsy. Okay, thank you. So, you know, I did this bone marrow biopsy again. And you can't imagine how surprised I was when I discovered that something had come of it. I am no pathology expert, I rely just on my colleague, but here's numerous vessels between bone trabeculae, often lined with epithelioid endothelial cells with eosinophilic cytoplasm, occasionally nuclear atypias, and positive staining for endothelial markers like CD31. Our entire case was referred to National Rare Bone Tumor Multidisciplinary Bone. The histology was compatible with a well-differentiated angiosarcoma, but the patient's presentation was discordant with this diagnosis. So a member present to this board suggested to send a sample of the peritoneum tissue to her lab at Léon Bernard Center in Lyon to do molecular biology via RNA sequencing. And this analysis finally allowed us to discover this gene fusion that was consistent with the diagnosis of vascular epithelioid tumors. Vascular epithelioid tumors are exceedingly rare and heterogeneous entities. Their diagnosis is very challenging due to their non-specific histological features, but also the very variable presentation for clinical and radiological features. There is no standard protocol. The management is largely empirical and depends on the extent of the lesion and the aggressiveness of the tumor. Tumors harboring this gene fusion exhibit a wide spectrum of morphologies and biological behavior, from vascular malformations to bone cysts and round cell sarcomas. As you saw, it really was a team effort. The diagnosis heavily relied on multidisciplinary collaboration, especially with our pathology department. We referred our case to national center networks to confront their experience, and finally, we used guided molecular biology to identify the underlying genetic alteration. Thank you very much for your attention, and I very thanks the French Society of Internal Medicine.
Thank you. I really don't envy the jurors. They will have a real tough time this year.
At McMaster, if we exceed 6 consultants for a case, we ask Dr. Panju. So maybe I will give you first comment.
Yeah. Thank you very much. This is an exciting, complex case. And as an internist who deals with complex cases, number one, why were you so interested in getting to the molecular level? Is it to find out something, to give it a label, or for etiology? And number two, in rare cases, does AI show a promise in identifying rare diseases?
Thank you for these questions. For the first questions, the tissue sample didn't allow us to do molecular techniques at the beginning because, CT-guided bone biopsy were inconclusive because the very small sample, it was crushed. The peritoneal biopsy, the second time, they didn't do fresh biopsy. So we didn't, we couldn't at that time at our institution do a molecular biology. Sorry. And for the second questions, I used artificial intelligence like ChatGPT, but it didn't propose this hypothesis. And it's at the moment that we discussed this case to a national network that someone proposed a novel techniques on the formal conditioned tissue at our lab. But without this, we couldn't have done molecular biology techniques.
Just a short comment on the artificial intelligence. All of you, of course, are invited to join the next session, which starts at 2 p.m. And then we will learn from those who create the AI tools how to use them. I'm not sure if it will scare me or make me enthusiastic, but anyway, I think this will be a great session. But this will be at 2 p.m., so now back to the discussion. No more comments.
Nobody knows.
Yep. All right. So we will save a minute or two. Thank you so much.